Hello, Takashi.
Hey, good evening. Good evening, John.
Yeah, yeah. You don't. I'm not on camera, but yeah, I see you.
Okay.
How you doing?
Yeah, I'm very fine. I'm very pleased to join.
Oh,
And a
great. It's
good
great.
poster, good banner.
Yeah, Warlick, you met her.
What make it a good banner? So
You met
I'm very
you met her, right?
yeah.
Yeah. You're gonna get known in Japan.
Yeah.
You're gonna get known. Yeah, we have to figure out how we can build the Japanese community so they know about
Yeah.
it. Do you know what I
Okay.
mean?
So
I don't
yeah.
know. I don't know if you have much knowledge of social media or have friends, but
mm,
I would like to hook up with friends if you have friends.
okay. Yeah.
You,
Some of the friends, some of the lists I know. My friends are also included.
yeah, okay. I'd be glad to meet with them to talk about how we can expand the Japanese neurosurgery community.
Yes.
Not only for
Uh,
this, but for doing their own webcasts too in Japanese
mm,
if they want.
okay. Yeah.
Do you know what I mean? Because in Japan
Yeah. Okay. I know. Yeah.
they're a little behind the Zoom technology as the
Yeah.
rest as the rest
Well,
of the
behind the
world.
Zoom,
You know that.
uh,
You know that.
I know. I know. I know.
So, but they will become adept at it because once they see it works, they'll
Mm,
become. I think. But anyways,
yeah.
I'll be back. Okay.
Okay.
Welcome, everybody. I'm John Bennett. So Tashi, what is the let me get off this here. Okay, remove spotlight. Okay. There, Tashi, is WeChat popular in Japan?
Sometimes in Japanese, using Line, like that WeChat, like Line, Line. WeChat is not so popular, but some are using.
Yeah, can you send me the main popular social media?
Social
for
media.
neuro-
Okay, so
Yeah, for
it
that
is
neurosurgeons use. That neurosurgeons use. You know what I mean?
Neurosurgeon's view. Okay.
Yeah.
We call
Yeah.
it Line and at Facebook Messenger.
Okay. Well, just yeah. Could you email me that? You have my email address, right? Oh yeah.
Okay.
Yeah. Messenger's fine.
Okay,
Messenger's
Messenger
fine.
is fine.
Well, the thing what I like about Messenger is that you can go back and see what I said to you and get get addresses. That I get a lot of addresses. Oh, Warlick's is here. That's good.
Warlick's is. We call it Line.
Oh yeah, yeah, Warlick. So you can tell Warlick's personally what you said.
Oh, okay.
She's
Okay.
here now.
Okay. To Warlick's.
Yeah, Warlick's. Are you there?
Warlick's.
Yeah, she.
Yeah.
Hey, Warlick's, how you doing?
Great. I'm called from the hospital.
A surprise visit.
Yeah.
Yeah, this is Tashi. You know Dr.
Yeah,
Tashi, right?
good
Tashi.
Oh yeah, we made a few
Yeah.
times with the
A few times.
conference, online conference, and he's going to translate it, right?
Yeah. Okay. So, sure.
Yeah, this is great, Warlick. You know, this is what I really want to do is get off the screen. So you're neurosurgical TV, okay, Warlick?
Okay.
Warlick's is also.
Yeah, and I don't even come on camera. You just say hi. I'm Warlick of Neurosurgical TV. Okay.
Okay.
Okay. No. That's okay. Your background's cool, and what I'd like you to do, Warlick. Hello, Ben.
Hello, John. Hello, Warlick.
Tashi's here.
Hi.
Your associate
Good evening.
in crime.
Hi, evening, Takashi.
Good evening, Dr. Bean.
Hi.
Yeah. Good evening. Good evening.
Yeah, we're just talking about how we can build up the community in Japan of Japanese neurosurgeons. We have to work on China too, of spreading the word. But anyways, Warlick, yeah, you're hi, I'm Norlix of Neurosurgical TV. And one thing I'd like you to do right away is to thank the translators. I like to, you like to.
Okay. Thank the translator.
Yeah, and welcome, a special welcome, and introduce the translators, and then a special welcome to the China neurosurgery viewers, okay? A special welcome to them, okay?
Okay.
Can you remember that?
What's a second?
No, write it down.
Okay.
Just two things. Just two things. Introduce translators.
Okay.
And then special welcome to the Chinese neurosurgery community and the Japanese neurosurgery community.
Okay.
So now that we're expanding a little bit,
Okay.
and that's it. And then you introduce Juha.
Okay.
I don't know if you want to say anything about him bringing us the best in our part of the world in neurosurgery. Do you know what I mean? just improvise. Because what Juha's doing, I mean, really is bringing the best of neurosurgery in our world, and he can get them. Do you know what I mean? If you can just convey that feeling.
Yeah.
But if you, okay, you get a lot of pressure there. It's like getting operating instructions just before you operate.
Yeah, like a lot of things to just still no patience.
Tashi, like your poster.
Yeah, thank you. Thank you.
Everybody says that. Okay, we got 12 minutes. Right back. Here's Juha.
Hello, everybody. Hello, John. Hello,
Hey,
Tubin.
Juha.
Hey, good evening.
Hi.
Hello, Varaluk.
Hi.
Hello,
Good
everybody.
evening from Thailand.
How you doing, Juha?
I'm fine. Fine. Yeah, fine. Spring is coming here. A
I
new
got my-
year. Chinese New Year also.
Yeah. Yeah.
Next
Oh,
week.
when is that?
In
Now?
1 week.
Oh, 1 week.
Next week.
Yeah, we take the week.
February 12th is the
Yeah.
New
Very
Year.
good.
We take the week off, right?
Yeah, we have a break during
Okay.
Chinese New
Oh.
Year.
New Year's.
Okay, that's a big celebration in China. More than 1 day.
Shubin can tell more about that.
Yes, we have around the 7 to 10 days
10 to
holiday.
10 days.
Oh, okay.
Mhm.
Yeah, many people come to Japan,
but that doesn't affect the neurosurgeon, right?
no.
We also have a vacation.
Yeah. Oh, you got a day off. A day off.
Yeah, yeah.
Yeah, 1 week. 1 week.
Oh,
All
whole
week.
week.
1 week.
Everything slows down in the hospital.
This year, very few people come to Japan because of COVID-19.
Yes.
The travel restrictions, right?
Many Chinese, we welcome many Chinese every year around this year, at this time of the year. However, this year, Olympic game will be held or not, so I'm not certain in Tokyo.
Oh,
Yeah.
that's right. The Olympics were scheduled when?
Maybe July, but I'm not certain. I'm not certain
Oh,
whether
so
it will be or not, because in Japan they're very discussing every day about the Olympic Games.
Oh, okay. Okay, well, that's a big decision.
Yeah, big decision.
But so far, travel is still pretty tight.
Yeah.
I got my vaccine yesterday, well, the first one.
Yesterday?
Ah,
Okay.
Yeah.
Okay.
Juha, have you got
Great.
your vaccine yet?
No, Petri
No.
hat. Petri hat.
Oh, Fitri has? Okay. How about you, Warlix?
Yeah, great. At the clinic today, but no patient yet.
Oh, really? It's early at the clinic? You're at the neuro, okay.
Yeah, this is like I'm really busy. It's like work 7 days per week. Like just come back from fellowship, so it's like just starting. Few patients.
So there's a line outside the clinic?
Yeah. And yeah, for COVID too, that affect people that normally if there's no COVID, there will be more patients and people will like easily get sick. But when the COVID come, people like have higher turn rate. So they,
Oh,
yeah,
that
still
could-
fine, waiting for the COVID to be gone. And I think they will get sick again. I don't know.
You have to be very,
Yeah.
very sick, right? To go to the hospital?
Yeah, I did like very few case now. Yeah, try to search a case.
Is it a drop-in clinic or they're all your patients?
Huh?
Is it a drop? What kind of clinic is it? Is it your clinic or is it?
Oh no, in a private hospital. I did not open my very own clinic yet. But I think that for the neurosurgeons to open your own clinic, it's for me it's like too much trouble. So just like work at a part time. That's all.
Yeah.
Yeah.
Oh, okay. Very good. So you haven't been traveling, right? You stick at home.
No traveling since 1.5 years.
Wow. Still no.
No,
Nothing.
no. Last year I was in Indonesia, but in 1 year, no travel.
Oh, okay. And it's still tight there?
Continues. You cannot
Really to
go.
go to Japan.
You cannot go out of China because if you come back, then you have 3 weeks quarantine. So it is hard quarantine.
Yeah, you can't work, right? Strict isolation. Those 3 weeks when you come back.
Say like.
Have you been to Japan, Juha?
Yeah. Several
Oh,
times.
okay.
Yeah, we're welcome to Japan, but after COVID-19.
Yeah.
Have you
Take 1
seen
year.
Juha in Japan, Dr. Takashi?
Not yet. So, but I want to see. I want to meet. I know a lot about from Finland, Helsinki, about you. So I'd like to welcome some meeting. So I'm
Thank
eager
you.
to visit also China
Next year.
next year. After
Now the
COVID-19.
rats year is ending and the ox year is beginning.
It's beginning.
Maybe the ox is better than rat. Rat year was very heavy.
Hi, John. Did you send the email to Atul?
Yeah, I'm doing that right now.
Oh,
I'm
almost
doing
there.
I'm doing WeChat actually.
WeChat, okay.
Yeah.
WeChat? I don't know how to go.
5 minutes, he said. Okay. Which is exactly on time. Warlix, we call Atul the Elvis Presley of Zoom.
Zoom.
He goes everywhere. He goes everywhere, man. I think he does the most Zoom of anybody. What do you think, Warlix? He does, yeah, he does a lot. But he's coming in 5 minutes. Okay.
Run this session. What is that?
Okay, here's a tool. Okay, at the very last minute, just like Elvis Presley.
Chinese time?
Yeah.
Hey, Atul, how you doing?
Hi, John, how are you?
Well, I know you had to make a dramatic entrance like Elvis.
I had some internet issues here and there, but now I'm set.
Beginning 11 o'clock in the night.
Okay, okay, we're ready. Are you ready,
Then
Atul?
Yeah.
Yes.
Are you ready, Juha?
I'm ready. Yes, yes, yes.
Okay.
Welcome, Atul. Welcome, Atul. You are a very busy man.
Thank you.
Okay. Okay, I'm gonna say 10, 9, 8, 7, 6, 5, 4, 3, and then Warlix, and you take it from there after I say 1, okay?
And I,
Okay?
Okay.
Warlix?
Yeah,
Okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hi everybody, welcome to Neurosurgical TV. My name is Dr. Pralak Pusungna, neurosurgeon from Thailand. Today, welcome to the Juha Neurosurgical's brand round as always, and welcome to the Chinese and Japanese neurosurgical communities. Today, we all have a great lectures again from very famous neurosurgeons. But today, I would like to introduce you that we are going to translate into two language in which Chinese by Dr. Bin Su, and Japanese by Dr. Takeshi Kons from Choba University, Japan. So today, we'll have a great lectures from Professor Atul Goel that he will present about the concept of cavernous sinus surgeries. He's the legendary neurosurgeon. He's the professor and head of the Department of SAIS GS Medical College and KEM Hospital, Mumbai, India. But first of all, I would like to introduce Professor Juha Haneshimi to welcome our great speakers today. So please, Professor Juha.
Thank you, Maralux. I will give a short introduction. My slides? It's okay?
Yes, we can
Yes.
see that.
Perfect.
Dear Professor Atul Goel, dear all, Professor Atul Goel from Mumbai, chairman of King Edward's Hospital, is one of the most important neurosurgeons of these times in the world. How to become a good neurosurgeon? Train hard, follow the way Professor Atul Goel is doing. There are many different levels of manual skills. Mainly it depends on the repetitions and length of career. There is an international rule of 10,000 hours of training, doing whatever. You will come to the world top in neurosurgery. This training begins, of course, later, and this is my own estimate that after 10,000 days in operation room, you are at the highest level of your skills. I think Atul Goel is at the top of his skills. At the same time, he has many years left. Neurosurgery has three parts. Operative skills, there is research, clinical research. Usually clinicians, neurosurgeons are doing clinical research, and then there is teaching. Professor Atul Goel is doing around 1,500 personal operations a year. It's an extremely high number. You have to be excellent neurosurgeon, organizer, surrounded by a good supporting team, and the patients and society. And of course, you have to have big population. This counts for India, which has nearly the same population than China. You should train your best young people. They should become better than you. I couldn't visit Professor Atul Goel's clinics because the COVID came just to prevent it, but I'm sure and have met Atul Goel with his team, and he's training them to become better than you. The young doctor Dabha Shah, a difficult name to pronounce for me, is certainly one of them, doing already her own webinars international in anatomy. And anatomy is extremely important in neurosurgery, and this is what also Professor Atul Goel is doing. Like Ali Christ, he certainly says that he goes to cover inside the cavernous sinus, like to his home. So he has also published a lot. He has numerous publications, more than 800, I think, at the same time. And already nearly 7 years ago, he was elected as one of the most important neurosurgeons, 69 important neurosurgeons here, beginning from Cushing, and Atul Goel is certainly #1 neurosurgeon in India, but like my teacher, late Professor Drake, was saying, one of the best, and certainly he's that in the world. So I don't continue very much because Professor Atul Goel is a passionate lecturer, and he will begin now. Welcome, Atul.
So just tell him 2 minutes.
Just a minute, Juha. I'm just trying to share my screen.
Yeah. Take your time, like John Bennett is always saying.
You gotta say that.
So whilst I'm trying to get my screen on, I must say that I'm extremely honored and very proud to be on Juha's show. There is no question that Juha is one of the legendary neurosurgeons, one of the highly technically skilled neurosurgeons of the world, and who has built a huge team of followers, huge disciples all over the world. So needless to say, I'm extremely honored and proud to be on his show. And I, as asked by Juha, I will like to talk to you about surgery involving cavernous sinus and some other skull-based tumors. So what I plan to do is, see, cavernous sinus surgery was not commonly performed about 30 years ago. It is only a 30-year period where cavernous sinus surgery was born and brought up and evolved into current situation. And without any question, Vinko Dolenz has got a great role in the birth of this huge branch of neurosurgery. Cavernous sinus surgery is difficult. Cavernous sinus is right in the middle of the skull. It is close to the circle of Willis, close to the pituitary gland, close to the internal carotid artery, close to the temporal brain. So it is right in the middle of the brain. So there is no way you can say, I don't want to do cavernous sinus surgery, or I am not interested in cavernous sinus surgery. I am going to take you to the journey of cavernous sinus, where I have myself been involved in more than 35 years in this beautiful subject. As Juha said, anatomy is the key, and we have to learn anatomy again and again and again, with injection, without injection, with micro dissection. You have to take your operation theater in the cadaver lab and do good and fine and beautiful dissection all the time if you really want to do cavernous sinus surgery. So these are the two books which I have written, and this was in 1996, so about 25 years ago. 25 years ago, I had written this book, and you can see the title, Neurosurgery of Complex Tumors and Vascular Lesions. And if you see, this book was written with Professor Kobayashi in Hongo, and the entire book, the beauty of this book was the whole book contained personalized techniques. It was personal published techniques were published in this book in 1996. More than 200 original techniques were published. So this was a monographic presentation. And more recently, I have published this book. So I will take you right to the birth of my journey with cavernous sinus and some philosophical issues and majority of technical issues. If we have to be technically good, we have to be philosophically good. If we have to be philosophically good, we have to be technologically good to implement that technique and philosophy. So there are several papers of mine in 1996. I'm giving you the list of papers where you can actually go down to the internet and see all these papers are available on internet. Cavernous sinus, a speculative note. Cavernous sinus and its role in eye movements. You see, this was a beautiful original hypothesis that cavernous sinus has a role in eye movements. Cavernous sinus has a role in eye health. So there are several philosophical issues which I have discussed in several articles which were never discussed in the literature. Nobody has ever discussed that cavernous sinus, this venous compartment, has some role in the body. We talk of anatomy and all right, but Does it have a role? So my papers speculate that it has got a major role in the function of eye movements and also vision. Now you see these 4 slides. This is an astronaut who is just weightless. This is fetus, which is just weightless in the womb of the mother. And this is the brain, which is weightless around the CSF. So fluids or water make the brain weightless. And the whole body is weightless because of the fluids. I don't want to go too much in these philosophical issues, but it is very important to know that fluids and membranes are absolutely critical in the birth of the human body, in the birth of every organ, and also it has got great implications in our surgery. So one implication is that water has a great role, and water is the mother. Water gives birth to the human body. And the brain floats on CSF and also on the blood contained in cavernous sinus. So these are some speculations. Eyeball is a very important hydrodynamic system. There is aqueous humor, there is vitreous humor, there is a lens, and behind the eyeball, there is pad of fat and large amount of veins which culminate into the cavernous sinus. All these fluid compartments have got great interconnection so that the retina, which is the most important sense organ, can function normally. If the pressure in the eyeball is more than normal, the retina will not work. If the eyeball is less than normal, it will not work, the retina. And the pressures are regulated from one compartment to the other compartment to the other compartment to the cavernous sinus. So cavernous sinus has a big protective role in the functioning of the eyeball. You see there is circle of Willis, but there is also a big circle of cavernous sinus and intercavernous sinus connection. And these connections are having a great role in having a binocular vision. So if you press one eye, the pressure goes onto the other eye and there is some diplopia for some time, and then the diplopia returns to normal. If there is a thrombosis of the cavernous sinus, if you press the eyeball, there will be big pressure and you can damage the retinal artery. So this is suggesting that cavernous sinus thrombosis results in eye movement loss, not because the nerves are lost, but because the venous circulation is lost. So this is a very important speculation. So we speculated that cavernous sinus has got a great role in eye movements and also has a great role in vision other than optic nerve, other than oculomotor nerves and other nerves. So this is the hand which supports the eyeball, and this hand is nothing but the cavernous sinus. This is my very favorite slide. I have shown this slide more than 200 times in my lectures. Why the eyeball in the deer is located laterally, and why the eyeball in a lion is located in the front. Because the deer, when it runs, it has to look in front, look behind, and run. The eyeball moves like front and back, front and back. So there are very vigorous movements of the eyeball. On the other hand, the eyeballs of the lion are right in front and the movements are not so big. So cavernous sinus of a lion is much smaller than the cavernous sinus of a deer. These speculations were discussed by Hakuba, who was one time very big anatomist and surgeon, as we all know. The eyeball of a fish is not only important for vision and binocular vision, but also for swimming. If you puncture the eye of a fish, the fish cannot swim and the fish will die. The cavernous sinus of a fish is much bigger than a human cavernous sinus. There are fat lobules in the cavernous sinus of a fish. So the speculation is vision and eye movements are controlled by cavernous sinus. Larger the eye movements, larger the cavernous sinus. So these are some speculation. These are the various kinds of eyeballs. Your beauty lies in the eyes, and also what lies behind your eyes. Behind your lies, of course, the brain, but also the cavernous sinus. So what I am trying to show you is some speculations. There are several speculations like this which I have written, and I wish you must read because they form an interesting reading and may be very important for us during surgery. So cavernous sinus is located right by the side of the pituitary gland. You see, this is the pituitary and this is the cavernous sinus. It has got great relationship with the internal carotid artery. It has great relationship with the sphenoid sinus. So this relationship of the cavernous sinus with pituitary, with paranasal sinuses is also very critical in regulation of the temperature of the human body. This is the speculation. So when we breathe hot air or cold air, as soon as it goes beyond the nose, it becomes normal temperature. This information is given to the cavernous sinus, and cavernous sinus gives this information to the pituitary gland. Carotid artery gets the information about temperature of the body, and this information cavernous sinus gets, and from here, the information is related to the master gland. So this is some speculation. I hope you have enjoyed it, and I hope you will try to read more about these speculations. John, there is some noise, just check.
Okay, we'll take care of that.
Okay. Okay. Another fantastic thing, which is the basis of my at least 50 articles in publication, in various publications. Alum al-Dimag is from the Arabic legacy. It means that membranes are the mother. Membranes are the mother of brain. Dura mater. Dura is mother. Dura is the mother of the brain. So this is from Arabic legacy, and we have to understand this terminology in a great context. And I will now like to show you that dura is so important for our body, and it not only keeps the whole brain compact and enclosed. No corona can enter into the brain. Infections can enter into the brain extremely rarely. And there is a protection, and there is a self-repair, immunity, and so many things which this dura, this compact compartment, is providing to the brain. Another beautiful sentence you will like to read: mandibular nerve does not pass through foramen ovale. Foramen ovale, or the bone, is fashioned around the mandibular nerve. It means that membrane comes first, mandibular nerve comes second, bone comes last in the embryonic development. Mandibular nerve comes first, and the foramen ovale comes later. Internal carotid artery comes first, anterior clinoid process comes later. So this is a very important concept. Now I will like to take you to the journey of cavernous sinus. I have been involved in more than 30 years or 35 years in cavernous sinus surgery, and I am showing you several articles which were very relevant, at least during those days and even now. And these articles you will like to keep for your reference. And you see the meningeal architecture of cavernous sinus, impact of arterial displacement on strategy of cavernous sinus. This was published in 1998, and surgery on cavernous sinus. You see, this is cavernous sinus. Carotid artery is encased by the tumor, and carotid artery is squeezed by the tumor. Here, the cavernous sinus encases the carotid artery but does not squeeze it. Here, the cavernous sinus displaces the carotid artery. So these pictures are from my 1998 article, where I said that how the carotid artery is displaced and how it is involved by the tumor has got great implication in understanding the nature of the tumor, understanding the pathology of the tumor, and understanding and deciding the surgical strategy for these tumors. So this article was in 1998, I think quite a good article, and I wish you will like to read it. So I am involved with very high profile neurosurgery of the skull base. So this tumor I had done in 1993 with very heavy petrosectomy. This was another case in 1995, going in cavernous sinus, going in orbit, going in front of the brainstem. This is another tumor. There is a small residue in this tumor, and I'm following up this tumor for more than 20 years without radiation. If you ask today, this will be immediately given radiation and all those things, but this patient is quite okay for so many years. This is another case I did in 1997. I operated this very radically, but some artery I damaged, and this patient developed quite a bit of hemiparesis and hemiplegia actually. He's still alive, but he's having hemiparesis. So I am wondering whether I could have been a little bit less radical or more radical, but this is my journey and this has been my life in the region of cavernous sinus. This was another very fantastic case. You see, there is one tumor behind the orbit, eyeball, and one tumor in the cavernous sinus. And this patient was taken by the plastic surgeon to remove the eyeball till the time I got to know, and then I shifted the patient to neurosurgery department. We removed the orbital tumor first and then the cavernous sinus 24 years ago. So this was the boy, very heavy vascular tumor. Hemangiopericytoma was this orbital tumor that we removed first, and then the cavernous sinus tumor. You see the eyeballs, and this patient is still alive 27 years later, absolutely fantastic. So cavernous sinus surgery has got great relevance in our field of neurosurgery. It is difficult, it is dangerous, it requires patience, it requires persistence, it requires hard work, but we have to understand these tumors. So now what I want to do is, I want to show you various strategies of operation on these tumors. So this paper we wrote on extradural approach to lesions inside the cavernous sinus, inside. Of course, we know the work of Vinko Dolenz, who has shown us approach to internal carotid artery aneurysms in an extradural fashion. Also, he talked about extradural approach to trigeminal schwannomas. This was the first paper which discusses tumors inside the cavernous sinus, inside, between medial to the Gasserin ganglion. So this, I am going to show you various tumors, and I will talk to you about strategy of resection of these tumors. This tumor is one of the most benign tumors of the human brain. This tumor is amongst the most difficult neurosurgical problem. This tumor is the most vascular tumor of the body. This is cavernous hemangioma of cavernous sinus. This is one tumor which is also very common in China. This tumor has very characteristic presentation radiological. It is completely intracavernous. The lateral dural wall is displaced by the tumor. Tumor extends towards the orbit. Tumor extends towards the Meckel's cave, and tumor extends towards the intercavernous sinus on the opposite side. So this is entirely intracavernous sinus tumor. You see this one, intracavernous. Carotid artery is encased by the tumor. So this case we did in 1991. At that time, there were hardly any preoperative and postoperative images of these tumors. There were very rarely these tumors were operated because of the high vascularity, critical location of these tumors. You see, even when the tumor becomes very large, you see the lateral dural wall is displaced. The tumor extends towards the intercavernous sinus. Tumor extends towards the Meckel's cave. tumor extends towards the orbit, internal carotid artery is encased. Angiographically, this tumor is occult, means it does not show the vascularity that the tumor possesses. So this can give you a false impression post-operative resection. So in the year 2000, we reported extradural for the first time in the literature. I know there are some people in China who are doing extradural approach to cavernous hemangioma of cavernous sinus now. But this paper was the first in the literature which talked about extradural approach to cavernous hemangioma. Cavernous sinus is an extradural entity, and cavernous hemangioma are located in an extradural compartment. There is no need to come from the brain. There is no need to come and remove any bone or any temporal brain or anything. This is an extradural approach. An extradural approach is the most philosophical approach for these tumors, which was published first time in the year 2000. We published this. So I will like to show you my very early case. This was the tumor. You see the lateral dural wall is intact. Dura of the intercavernous sinus is intact. Internal carotid artery is encased, and this tumor has been resected. I want to show you this tumor was operated some 25 years ago, and just see the blood and see the bleeding. There is no need to coagulate too much in these tumors. These tumors bleed from the branches of internal carotid artery within the cavernous sinus, and you have to very rapidly. You see, this is V2, V1. I'm trying first to expose the tumor between the V2 and V1. So this video is a very old video, more than 20 years ago. You see, I'm working within the cavernous sinus amongst bleeding. So the tumor is bleeding very heavily. This tumor is a vascular tumor. This tumor is a benign tumor. First thing that you have to do is identify and save the sixth nerve. You see, this is the tumor in the cavernous sinus. I have now identified the sixth nerve inside the cavernous sinus. And then I am working around the tumor, saving the sixth nerve. And then I will identify the internal carotid artery, of course, very early in the operation. This is the internal carotid artery. And once you take some branches, the inferior trunk of the cavernous sinus, the hemostasis is quite easy. So to coagulate the tumor, initially you come a little bit from the outside of the tumor, and this patient has come with a third nerve weakness, and you see the eye movements have come back to normal within 2 months of surgery. These patients come with very severe headache, and these patients come with eye movement disturbance. But we have to be absolutely careful because of the vascularity. You can damage the sixth nerve, and if you damage the sixth nerve, you have damaged a lot. So this is another tumor I will like to show you. This is intracavernous hemangioma. This is an extradural exposure. So what I am doing is I am working transgastrian ganglion. I am opening the fibers of the gastrian ganglion. And I am working within the cavernous sinus by opening the gastrian ganglion. The fibers of the gastrian ganglion. Actually, this tape is completely unedited tape. I am only running it from here. This is not and you can imagine the high blood loss which is happening here. But I am absolutely convinced that there is no major point in coagulating very heavily in these tumors. Most important is to identify the sixth nerve early in the operation, save the sixth nerve, work over the carotid artery, not lateral to the carotid artery. Then I will identify the branches of the cavernous sinus carotid artery, and then I will remove this tumor completely. You see this now, the cavernous sinus vascular bleeding is happening. And now I am removing this tumor from within the cavernous sinus. And you must remember that once you remove the tumor completely, and once you remove the tumor, you will give a benign, this benign tumors very rarely recur. And you give a most important symptom in these patients is headache. So my strategy is understand the dural anatomy of these tumors. These tumors are extradural tumors. Work extradurally. Work first, save the 6 nerve fibers, and then the hemostasis is not difficult at all. So this is preoperative and postoperative scan. There was another huge tumor. This is cavernous hemangioma. You see the lateral wall is intact. The tumor is going into cavernous sinus towards the opposite cavernous sinus, going towards the Meckel's cave, going towards the orbit. There is an aneurysm, like feeding artery aneurysm of AVM. I have clipped the aneurysm. This was also more than 20 years ago. And you see this is postoperative, and this patient completely asymptomatic. He had eye movement disturbance. There was no improvement in eye movement, but the patient is completely otherwise asymptomatic. This is another tumor. So during the period, I have personally operated 43 cases of cavernous hemangiomas myself, which I believe is one of the largest numbers in the world. Now I want to show you the dural anatomy of pituitary tumors. You see, there are several articles of mine on pituitary tumors. I will take you through my own concepts of pituitary tumors, which I believe are very fantastic concepts, and you will like to hear them. These kind of large pituitary tumors, you see these large, huge pituitary tumors? This is also a huge pituitary tumor with a cystic fluid level. You see multiple fluid level within fluid cavities. These are other large, huge, giant pituitary tumors. So what I have written about it, that these giant pituitary tumors, although become giant, they remain within the confines of the mother dura. You see, as the tumor grows up, the diaphragm cell grows up. So the dome of the tumor is covered by the diaphragm cell. I have no doubt in my mind that this concept that the diaphragm goes up has completely revolutionized pituitary tumor surgery. And we introduced this concept about 25 years ago, that as this tumor grows, the diaphragm goes up. There is no artery of the circle of Willis inside the tumor in selected cases. So these tumors I have called grade 1, which do not go in the cavernous sinus. You see this very clearly. The dura goes up. So this concept, even Jules Hardy has said that this tumor becomes subarachnoid and can encase the arteries. Absolutely revolutionary concept that the dura is elevated by the diaphragm dura. You work within the tumor, the whole dura will ultimately come into the picture. So this was first concept about pituitary tumor. You see, this is the dura. Even this nubbin, this small nubbin, there is dura here. It is not intradural, it is not subdural, it is not subarachnoid, it is extradural or within the dural compartment. This tumor is not going in the brainstem. There is a dural cover. If you have this concept, you can operate this tumor. If you do not have this concept, you cannot operate this tumor. That there is a diaphragm celli dura which covers the tumor. There is dura of the cella which covers the lower aspect of the tumor. You see this tumor, it is going into the brainstem, but there is a beautiful, well-defined dura which makes a plane of dissection. So this dura, we introduced this concept that diaphragm celli dura covers the dome of the tumor. Grade 2 tumors are those which enter into cavernous sinus. You see, when the artery is encased by the tumor, lateral dural wall is intact, diaphragm is intact. So this concept is very important, that lateral dural wall of the cavernous sinus is intact, diaphragm is intact. So this is grade 2 when the tumor enters into cavernous sinus. Why some tumor enter into cavernous sinus, why some do not enter is a different subject. So diaphragm dura is intact, lateral dural wall is intact. Both cavernous sinuses are involved by the tumor. Now you see beautiful. Diaphragm celli dura is stretched. Lateral dural wall is stretched. Diaphragm dura is stretched. Cavernous sinus dura is stretched. Okay, these are grade 2 tumors. Now you see carefully this tumor. Lateral dural wall is intact. Diaphragm is intact. You see here, diaphragm is elevated, and there is elevation of dural wall or the roof of the cavernous sinus. So this is under the dura, lateral wall dura, roof of the cavernous sinus is here. Now you see this one, the diaphragm celli dura. This is the dura of the roof of cavernous sinus. So these are very important concepts. This is the diaphragm celli dura, and this is the elevation of the dural roof of the cavernous sinus. So when this elevation happens, I call it grade 3. Lateral wall is here. So you see, this looks like a very complex tumor, but this is not complex. It has got a method in its spread. This is elevation of the roof of cavernous sinus, elevation of diaphragm celli, elevation of roof of cavernous sinus. Grade 4 tumors are very rare when the artery of circle of Willis is encased by the tumor. This is a rare kind of situation. I call it very aggressive or malignant pituitary tumor because they do not respect the mother, they transgress the mother and encase the arteries of the circle of Willis. So this is my classification. Grade 1, when the diaphragm is elevated, but the cavernous sinus is not involved. You see the tumor has gone beyond the corpus callosum. Grade 2 is when the tumor involves the cavernous sinus, the lateral wall is intact, the diaphragm is intact. Grade 3 is when the dural roof of the cavernous sinus is elevated. Grade 4 is when the arteries of circle of Willis are encased by the tumor. So my concept about diaphragm celli, my concept about the roof of cavernous sinus, my concept of lateral wall of the cavernous sinus, I believe are very important if you have to remove the tumor within the cavernous sinus and remove the tumor which elevates the roof of cavernous sinus. So this is surgery of these tumors. Even when they become large, you just open the anterior wall of the sella, debulk this tumor. These tumors, pituitary tumors, are soft tumors. They are vascular tumors. So you have to learn the art of breaking the tumor. You have to learn the art of demolishing the tumor. You don't have to keep on coagulating within the tumor, which is absolutely not necessary. You open the anterior wall. You don't have to remove the planum sphenoidal, tuberculum celli, no need. Go enter here, break into the tumor, and very soon, within 15 minutes or 20 minutes, the whole diaphragm will come into picture and you will have a beautiful recovery in the vision in the immediate postoperative period. So this is like a uterus. You see, the uterus is the strongest muscle of the body. Uterus pushes the baby out. Uterus, if we go trans-abdominal or cesarean section, it is a negative operation. The natural way of delivery of the child is by pushing the uterus. So this is a pregnant tumor. You remove the anterior wall, debulk the tumor, and the whole uterus will come into your picture within quick time. What we have to do is learn the art of breaking the tumor, learn the art of demolishing the tumor, learn the art of operating within a bloody, bleeding territory. If you keep on coagulating and if you want a clean, bloodless field, you cannot operate these tumors. So these tumors are, we have now got an experience of more than nearing 5,000 pituitary tumors. And this is my wonderful experience with giant pituitary tumors. Even when the diaphragm goes right up to the corpus callosum, the diaphragm is intact. This concept you see the diaphragm is intact. The diaphragm is intact. When the tumor goes in the subfrontal area, I must tell you, 25 years ago, all these tumors were operated by transcranial route. But if you know that the diaphragm is going to be intact, I remove this tumor in exactly 20 minutes by just removing the anterior wall, debulk the tumor, and you can actually get the wall of diaphragm into your picture. So you see this is going here, but it has been removed beautifully in very quick time. I removed this tumor 20 years ago. You see this with the anatomical understanding that the diaphragm is intact, and you see this tumor from the nose. Whether you use endoscope, whether you use microscope, that is a very flimsy concept. Concept is the understanding of the dura, understanding and your experience in demolishing or breaking the tumor, and you can remove these large and huge tumors in very quick time. 22 years ago, I removed this huge tumor by just removing the anterior wall of the sala. And you can see in the immediate post-operative periods, there is some blood here. And this patient came back after some time with a recurrence. But this is a beautiful tumor resection. And you can see this 21 years ago. Important is, you must know that the dura is going to save you. About cavernous sinus. Cavernous sinus, you have to understand absolutely critically the anatomy of internal carotid artery, anatomy of the sixth nerve, how the sixth nerve goes into cavernous sinus, and more importantly, when you should operate within the cavernous sinus. Whether you should operate or not into cavernous sinus is a very important question in non-functioning tumors, whether you will like to do or not do, whether in functioning tumors. So although I am not very hesitant to do transcranial route in some functioning tumors, but these tumors are completely removable through the nose. This, you see, this is elevation of roof of cavernous sinus. This tumor is causing chiasmal compression. So I remove this tumor, this residual tumor. This residual tumor is a very big indicator of recurrence. So when there is a grade 3 pituitary tumor of this kind, you have to remove this tumor. This tumor also I removed several years ago. You see there are two compartments of this tumor. There is elevation of roof of the cavernous sinus, diaphragm celli elevated, and you enter into the cavernous sinus. Respect the dura. The third nerve can be in a critical zone. So you have to understand the consistency of the tumor, the vascularity of the tumor, and then try to remove the tumor which is going into the dome of the roof of the cavernous sinus. These tumors, what to do when the tumor goes beyond the artery of circle of Willis, these are malignant pituitary tumors. These tumors, you have to be very gentle in resection, partial resection. Now over the period of years, I have realized that these tumors respond to radiation. That is one thing. And many of these tumors are prolactinomas. You give antiprolactinoma drugs, and chemotherapy is a beautiful option for such tumors. You must do very high profile endocrine assessment for these tumors. Now I want to go into another beautiful tumor of cavernous sinus. These tumors are trigeminal neurinomas. I published this article, which is very highly cited article, in the year 2003. In this article, we published that these tumors arise in the region of the Meckel's cave. And the tumor in the cavernous sinus is between the layers of the dura, between interdural in location. The mother dura is encasing the tumor here, mother dura. In this article, I had written that this tumor is like acoustic tumor and is subarachnoid in location. But then we realized subsequently that many of these tumors are also within the dura. In this article, for the first time in literature, we mentioned that trigeminal sensations can improve after surgery. The facial sensations can improve. So this was the first paper as a series which shows that the facial sensation can. So this article was very important article. We have to understand that this tumor is within the dura. Open the dura, work within the dura. You will, carotid arteries away, cavernous sinus is away, demolish the tumor. Many of these tumors are soft tumors and you can do a quick job. My experience with trigeminal neurinomas is nearing 300 cases, which is the largest series in the world. In the year 1995, You see, we described infratemporal fossa interdural approach. You see my hands, I just opened the zygomatic arch, opened the Meckel's cave, worked within the dura and did not do any craniotomy, no craniotomy between the dura resection. So infratemporal fossa interdural approach. Although I don't do it too often these days, but this shows that your understanding of dura is so important on the basis of clinical examination, on the basis of symptoms. You can identify which tumor you are going to operate. Carotid artery is displaced by the tumor in a very characteristic fashion, and then you can decide your surgery. So this tumor is published, this pictures are from my article in 1995. On the basis of clinical examination, radiological examination, we identified this as trigeminal neurinoma and worked this tumor without a craniotomy. In 1994, I did this tumor, which was going in the posterior cranial fossa with just opening of the Meckel's cave. Interdural surgery. Work within the dura, and you can remove this tumor. Of course, I don't do this approach very often these days. And this was also done by just opening the Meckel's cave, working within the dura. And this is a beautiful way of understanding these tumors, understanding how the mother dura encases these tumors. So this part of the tumor is interdural. Even this part of the tumor can be interdural in location. Come from lateral, come from basal subtemporal, open the dura, the trigeminal nerve will be displaced, open the trigeminal nerve, demolish the tumor, quickly break the tumor, learn the art of breaking the tumor quickly. Carotid artery is protected by this layer of dura, venous plexuses are away from the field, and you can do a very quick job for these tumors and a very result-oriented operation. So this is a posterior fossa extension, which may also be covered by the dura. So in the year 1991, such tumors were operated in 2 stages. And those who are, more senior neurosurgeons, I'm not sure how Juha would have done this in 1991. So we did this in 1991 in 2 stages. So first I removed this tumor, then I removed this tumor, and this was in 1991. So in 1992, I removed this tumor first, and then I removed this tumor. You see this removed, and then this removed. So it was done in 2 stages. But as we understood the anatomy of trigeminal nerve and the dura, the mother dura, then we started removing these tumors between the membranes of the dura. So we published this basal subtemporal approach for large multi-compartmental trigeminal neurinoma, where we removed the root of the zygoma, the roof of the condyle, the roof of external ear canal, and included mastoidectomy. For the first time, we did basal subtemporal craniotomy and included mastoidectomy, like petrosectomy or petrosal approach. But this subtemporal approach included mastoidectomy for the first time. So this was my strategy. I don't need this extensive exposure these days. I now just split the temporalis muscle and work in a smallish compartment, and then basal extradural. If it is large tumor, I work intradural, open the lateral dural wall, then work within the dura, then extend my extension into along the tentorium. Superior petrosal sinus has to be protected. So these tumors can be easily removed in single stage. Basal subtemporal approach, save the trigeminal nerve, demolish the tumor, demolish the tumor, demolish the tumor. There's a huge opening here. Then you open the tentorium and then you remove this tumor. Basically learn the fact that these tumors have a well-defined dural coverage. So we have, as I mentioned to you, I have nearing 300 cases with these trigeminal neurinomas, and these can be done in a quick time. Vinko Dollens has also described an extradural approach. We discussed about interdural approach for these tumors. Even when there is a small nubbin, you see small nubbin but this is not transgressing the dura. This is within the dura. So you must remember the whole tumor is within the dura. Many a times this posterior fossa component is also within the dura. Learn the art of breaking and demolishing the tumor without heavy coagulation, and you can remove these tumors in very quick time. So this I have done several years ago. You see the tumor has already destroyed the anterior clinoid process. Tumor has already done petrosectomy for you. There is no need to do any petrosectomy. There is no need to do any anterior clinoidectomy. Work within the dura. Learn the art of breaking the tumor, and we can get fantastic results. Another beautiful article I wrote is when the tumor goes extracranial. You see, this is V1 division. This is V2 by the side of the teeth along the V2 division. This is along the mandibular nerve. This is V3 division. Even the extracranial extension is within the dura. So this is the very important concept, that this part of the tumor is also within the dura, and you can do reverse transcranial. So open the skull, come in a downward or reverse transcranial approach, reverse skull base approach, open the lateral wall of the dura, and then extend your exposure downwards, and you can remove these tumors, keeping everything in this area under direct control. So interdural approach for trigeminal neurinomas which have extracranial extension. Another fantastic concept is even when there is a recurrence of this trigeminal neurinoma, when they recur, even when they recur, the tumor is within the dural compartment. So this is another very important thing. You see, I published my series of 284 cases some 1 year ago. Recurrence is also within the dural compartment. Now I want to show you another tumor. You see, this tumor looks a very complex tumor, but this patient presented with third nerve palsy. This is a third nerve neurinoma. So we identified that these third nerve neurinomas are completely covered by the dura. The entire dural tumor is within the confines of the dura, or the third nerve is within the dural confines. This is not the capsule of the tumor. You work within the tumor, this is soft tumor, and leave the dura, and you can save the third nerve. So we reported this long time ago, that these tumors arise from the cistern of the oculomotor cistern, and when it grows, it takes the dura, and this tumor is within the dural compartment, and the whole tumor, it looks like a very complex tumor, but this is within the dural compartment, and you can save the third nerve. You see, it has never been reported in the literature that you can preserve and improve the third nerve. You should not remove the dura around and demolish the tumor within the dural compartment. You see, this is another third nerve neurinoma, very beautifully well-defined dural compartment. The whole tumor is covered by dura. This is not the capsule of the tumor. You come and identify a safe compartment to enter into the dome of the tumor, debulk the tumor without heavy coagulation in a quick fashion, and you can save the third nerve function. So this was my article. Sixth nerve neurinomas are one complex tumors. We are trying to understand these tumors, but they are one schwannomas which can have a very discrete dural compartment understanding, which we will, we are trying to understand these tumors. I want to show you another tumor, which is a seventh nerve neurinoma. You see, this is a tumor arises, this is a seventh nerve neurinoma. It arises from the geniculate ganglia. And when it goes in front and when it goes behind, there is a dural cover. And this is very important to understand. We reported this subtemporal interdural approach. You come from here, open the dura, work within the tumor, small exposure. You don't need to do huge exposure. Work within the dura, avoid the course of the seventh nerve. And you can, I'm not saying you can, I have saved the seventh nerve, but you can preserve and you can probably improve the seventh nerve function, which is, of course, requires then big reconstruction. So facial nerve neurinomas are also within the dural compartment or interdural in location. Lower cranial nerve neurinomas. Lower cranial nerve neurinomas are also interdural in location. See, this is a very beautiful concept. In this article we wrote that you can improve the function of the lower cranial nerve shown when you operate on lower cranial nerve, which has never been described in the literature. You see, this is the tumor in the lower cranial nerve, goes along this. If you know that the tumor is completely within the dura and the other lower cranial nerves are displaced around the dura, so you identify a good spot of entering the tumor, debulk the tumor, and you can improve the function of the lower cranial nerves. So this is a beautiful concept which you will like to use even when the tumor is extracranial, work within the dura, and you have to preserve the whole dura around the tumor, and you can improve the function of the lower cranial nerve. So these are the pictures showing the dura and the tumor and how the dura is displaced. This is mother dura, dura mater or dura mother, which is very reliable compartment for dissection. Another skull-based tumor, this is, you see, this is the C2 neurinoma, C2 nerve, C2 ganglion, C1 arch of atlas, C2 axis. C2 ganglion is the largest ganglion of the spine. Gasserian ganglion is the largest ganglion of the brain. Gasserian ganglion is surrounded by the carotid artery. C2 ganglion is surrounded by vertebral artery. Gasserian ganglion is surrounded by cavernous sinus. C2 ganglion is surrounded by huge venous complex. C2 ganglion also has C2 ganglion is located behind the C1, C2 articulation. So we reported for the first time in the literature that C2 neurinomas can be removed without any laminectomy, no exposure. Like we described, trigeminal neurinomas can be done without craniotomy. C2 neurinomas can be removed without laminectomy. We also described that C2 neurinomas are interdural in location. Some years ago, first I described that this part of the tumor is intradural, like trigeminal neurinoma. You see, this part we described in my article in 2008. This part I said that this is intradural and this is interdural. In the year 2018, I described that this part and this part whole are interdural in location. You make a cut here, demolish the tumor, learn the art of breaking the tumor, vertebral artery is on the side. You don't have to expose the vertebral artery, and you can do a very fantastic and radical resection of all kinds of C2 neurinoma. So C2 neurinoma and trigeminal schwannomas are very equal in the anatomical location. They are within the dura, within the dural compartment. Within the dural compartment, these tumors can be removed without craniotomy, and these tumors can be removed without laminectomy. You can see very similar. These tumors I can remove in half an hour, complete operation, just open. C2 nerves are not very important. Trigeminal nerves are very important. You cannot damage the trigeminal nerve. So now I will take you to another skull-based tumor. I hope you are enjoying. Ben, you are able to hear? Ben? Okay, now I hope you are enjoying these concepts. So I will now take you to another tumor. This tumor is a chordoma. This tumor is a very favorite tumor of skull-based surgeons, and I have been involved in chordoma surgery for several years. I want to show you the anatomy of chordomas. Chordomas are very characteristic tumors. They demolish the bone, but they cannot transgress the mother dura. These are, even if the tumor is like this, the dura is intact. They displace the soft tissues. The cavernous sinus is displaced. The carotid artery is displaced by the tumor. This is carotid artery on the anterior surface of the tumor. This is a very characteristic relationship of chordoma. Trigeminal nerve, neurinoma, the artery is displaced medially. Chordoma, the artery is displaced laterally. Dura is always intact, extremely rarely. You see this article I wrote in the year 1995. This is chondrosarcoma. the whole tumor displaces the carotid artery anteriorly. Here, the tumor is located here. The carotid artery is normally traversing like this, but the whole artery is displaced along the anterior border. So the lateral course, the lateral attack to the chordoma is a beautiful surgical strategy. So we reported this middle fossa subgastrian ganglion approach to Clivus chordomas. It demolishes the bone, it displaces the soft tissues, it displaces the carotid artery, work within the dura, This posterior dura is intact, and these are soft tumors. You have to remove the bone around the tumor, and you can do a beautiful, if you have this concept that the dura is going to be intact, you can do this operation in a quick fashion, and you can do a beautiful resection. You see the internal carotid is displaced anteriorly, the dura is displaced posteriorly. So this is a very beautiful compartmentalized tumor. Work within this compartment and you can demolish this tumor in very quick time and very rapidly and very safely. So this is one tumor, chordoma, Clivus chordoma, lateral approach. Of course, you will say, I will like to do from the nose, I will like to do using endoscope, but I must say that, of course, you will like to do by various endoscopic and transnasal routes. But even transcranial is a beautiful option for these tumors. You see, if you can identify the sixth nerve by the nasal route, you may not be able to identify the sixth nerve. And that can be in danger if you are doing by the nose. And these large tumors which go laterally, which involves the cavernous sinus and which goes laterally, I think transcranial route is a beautiful surgical option in selected cases. We also do using endoscope in several cases, but transcranial surgery is also a good option. I want to show you another approach for Clivus chordoma, supracerebellar approach. Supracerebellar approach. You will be surprised to note now this tumor, which is going quite in the posterior aspect. So this tumor, as we know, the sixth nerve can be in great danger. So what we do is come from supracerebellar, like this. Remove the tumor, identify the sixth nerve early in the operation, separate the sixth nerve, and you can then have a good shot in the middle fossa like this, and you can remove this tumor. I'm not saying this is a preferred approach of mine. I don't do this often. This is very rare, but for saving of the sixth nerve, this can be an option. This tumor goes in the clivus here, and this is a chordoma. You see it going in the clivus. This is clear to come from front. Maybe an option to come from the nose, but to come from supracerebellar. Identify the sixth nerve early in the operation, and you can do a good resection. You can try to save both the six nerves and save them very nicely. So this supracerebellar I did for even this huge tumor. I came from supracerebellar and then attack. So this is an alternative option. You like to come from the nose. From the nose, this distance will be very big. I'm not saying nasal approach is not good. Please don't misunderstand me. I am also doing transnasal approach very often. Endoscope I use quite often. But many of these tumors, even a posterior fossa retrosigmoid approach, supracerebellar approach can be an option. Now you see tumors in the anterior cranial fossa, some tumors. This is a nasopharyngeal angiofibromas. These are not only extracranial, but they are extradural and extracranial. So these are nasopharyngeal angiofibromas, which are very heavily vascular tumors. You can define this mother dura is never transgressed by this tumor. So you can define a very beautiful plane in the basal dura. We described in 1994 this approach, transcranial approach for these tumors. But nowadays, I don't do transcranial, sublabial, midfacial degloving approach. Preserving the dura and dissecting the dura is a beautiful option for these tumors. Cavernous sinus can be involved with various other tumors like epidermoid tumors, dermoid tumors, aspergillomas. We have got at least 12 or 13 aspergillomas or even more. And this is a tuberculoma involving the cavernous sinus. Now I want to take you finally to meningiomas, which is a controversial subject. I don't want to go into a deep discussion about these meningiomas, but cavernous sinus meningiomas, we have to know how we will remove these tumors. So these tumors also have a philosophy. This is a convexity dural tumor, meningioma. It is not going into the superior sagittal sinus. So these are more benign tumors. When the tumor involves the superior sagittal sinus, it becomes more aggressive, inherently more aggressive meningioma. When the tumor involves the paranasal sinuses, it becomes almost like a malignant tumor. When it involves only the sinuses, it becomes this is a meningioma, which is, as you can imagine, these are aggressive or malignant meningiomas. Similarly, same concepts are very valid for meningiomas involving cavernous sinus. They come on both sides of the dura. They encase the carotid artery when they come into cavernous sinus. When the tumor is outside, when the tumor involves the lateral wall and outside the dura, they are more benign tumors. When the tumor involves the cavernous sinus, they are more aggressive cavernous sinus meningioma. And when they involve the cavernous sinus and come into the sphenoid sinus, they are almost like malignant tumors. So we have to understand these tumors when we are going to remove this tumor. So this is one tumor which we removed long time ago, completely within the cavernous sinus. This is a meningioma we removed, and there is a recurrence of this tumor. So these tumors, meningiomas which are within the cavernous sinus, are inherently more aggressive tumors. This is another tumor which is within the cavernous sinus. I removed this tumor, very heavily vascular tumor, and there was also a recurrence of this tumor. So these tumors which go into the paranasal sinus, go into cavernous sinus, are vascular, are basically that we have to understand. So this tumor is getting supply from the lateral wall of the cavernous sinus, and this tumor is completely outside the cavernous sinus. These are very good tumors to remove, but we have to take care of the arteries, middle cerebral arteries. So you have to work very beautifully, break the tumor, learn the art of demolishing the tumor. The whole field of tumor surgery is how you break the tumor, how you handle the tumor, how you handle the bleeding, how you dissect in the subarachnoid plane, how you save the arteries, and that is tumor surgery. You see, this tumor is arising from the posterior wall of the cavernous sinus, and you have to remove this tumor, and this can be very fantastic, benign, long-term outcome can be very excellent. You see posterior wall of the cavernous sinus, and you remove this tumor. So what you have to do is, this tumor is also from the lateral wall of the cavernous sinus. These are very straightforward tumors to operate. In my journey of skull base, in my journey of cavernous sinus tumors, in my journey of petrosal tumors and all kinds of anterior clinoidal meningiomas, my exposures were very huge early in my understanding of these tumors. I used to mobilize the facial nerve, and many of these articles show how to mobilize selected segments of the facial nerve. So this article was also very popular 25 years ago, but now I have stopped doing very heavy basal exposures, learn the art of breaking the tumor, learn the tumors themselves. So these petroclival meningiomas, you see, I used to do very heavy exposures for these tumors, but now I described this in 2004, and I am doing supracerebellar approach. Believe me, I can tell you that this supracerebellar approach is becoming very popular these days, and this is a fantastic. Only thing is, you can do in lateral park bench position, but if you are familiar with sitting surgical position, these tumors can become very straightforward tumors. Now I have done several tumors. In the year 2004, I reported 28 cases. Now I must have done several cases with supracerebellar. It's a very fantastic approach for these tumors. How much to remove? Whether to remove, this is also supracerebellar approach, whether to remove the part in the cavernous sinus. How to save the sixth nerve is a very critical issue in petroclival meningiomas. If you damage the sixth nerve, you create a very big disaster. You have to save the sixth nerve, you have to save the third nerve. How much to remove? It is not necessary to remove the tumor completely. This is basic understanding of tumor surgery. If we are going to damage the nerves, then we have not done a good job. So this is another tumor which is very straightforward, done by supracerebellar route. You see some tumor is remaining here. This is even the part which is entering into the Meckel's cave or into the trigeminal, through the trigeminal nerve, you can remove this tumor by a supracerebellar approach in a very fantastic manner. This is another tumor. So, of course, you have to do basal exposures. Of course, you have to remove the part of the tumor which is going in the cavernous sinus, and you can have a very beautiful straight direction towards the cavernous sinus. Most important is you have to know the anatomy. You have to understand how to break the tumor. The whole tumor is encasing the basilar artery. Tumors which encase the arteries are soft tumors. Tumors which displace the arteries are firm tumors. Tumors which encase the arteries are soft and vascular tumors. Tumors which encase the arteries are more aggressive form of tumors. But you have to learn these tumors and learn the art of breaking the tumors. I have got some, I hope my video works here. I'm not going to show you many videos, but you can see the huge exposure you can get from the supracerebellar route, and you can have a very dramatic exposure for all these tumors. And I have a feeling that, and you can expose the tumor in quick time. Come in this here, the trigeminal nerve is displaced, come over the tumor, start debulking the tumor, break into the tumor, and you can do a quick and very rapid job in many of these tumors. So these are several tumors. This part of the tumor around the third nerve I have left behind, but more important than removing all the tumor, you have to see to it. Unfortunately, this video is not running. So this tumor can also be removed in a very beautiful fashion by a supracerebellar, and you can actually expose the complete bifurcation and vertebral artery in a supracerebellar format. So what I'll do is I will, in the meantime, I will show you this video after some time when you ask me questions. So this is the tumor. You can remove the part in the cavernous sinus beautifully. So my most important thing is, as Juha has said, and we must understand, we in India and we in China have the advantage of several tumors, several hundreds and thousands of tumors. This advantage we should use, and to our learning, to our growth, to our understanding of these tumors, and then we can radically resect these tumors. In the year 2002, I reported 70 cases of tuberculum celli meningioma. Now my series is beyond 300 cases. Olfactory group, this was the largest personal series reported in the literature. This I reported anterior clinoid meningioma, which was quite a big series with the new grading scale. Foramen magnum meningiomas, I showed that you can do by a minimum exposure from the midline posteriorly, surgery on anterior foramen magnum meningioma using conventional posterior suboccipital approach. In 2001, I described, open the midline, open the dura, work within the nerves and save the artery, and you can do a quick job. I think, as I have developed, ossified tumors can be removed. I will show you some, and then I will, you see this is a bony tumor. This is CT scan showing complete ossified tumor removed by a midline posterior approach, complete resection. This is another bone. You see this is CT scan showing complete bone, and it is encasing the arteries, and you remove this tumor by a midline posterior fossa approach. It is another bony tumor encasing the vertebral artery, and you remove the, you see this on T2, it is completely dark. This is another tumor which can be done in a quick time and quick fashion with a midline approach. As regards meningioma, I will say curing is a non-issue in treating meningioma. We have to remove meningiomas radically. We have to remove meningiomas safely. We have to be aggressive in our attitude. But aggressive does not mean you can damage the nerves. Aggressive does not mean you can damage the patient. Aggressive exposure, radical Another beautiful sentence I am giving you: recurrence of a meningioma is independent of the extent of tumor resection. I don't believe that if you remove the tumor radically, remove the dura, remove the bone, the recurrence rate will be less. Particularly, this is relevant for cavernous sinus tumors and skull-based tumors. It is not the treatment, but cellular behavior of the tumor that decides the outcome and whether the tumor will recur or not recur. So thank you, my dear friends. Thank you, Juha, for inviting me. Thank you, Bin, for giving a beautiful translation for my lecture. And I will be very happy to see if there are any questions for my presentation. John, over to you.
Okay, thank you, Atul. Great. Okay, Juha, do you want to lead the discussion?
Thank you, Atul. It was one fantastic lecture. Giant attacking giant tumors. So you have been my hero a long time, and this lecture increased these feelings very much. So you are speaking not from your brain, but you are speaking from your soul, from your heart. You are 110% a neurosurgeon. You are like doing surgery when you are lecturing, and this affects all who listen here. So this is very difficult cases. Every case would have been very difficult to do by me and by many of other neurosurgeons, but you seem to go there very well. And what is extremely important, you have published your experience, you have shared the experience with the whole world, and this is very important. So you have analyzed your surgery, you have very creative thinking in your surgeries, and you try to find always new concepts, ways to treat these tumors. So I admire you very much. So this is what I wanted to say, and I can give the word to others.
When these words come from Juha, a person like Juha, who is not only a celebrated international neurosurgeon, not only a technical master, not only a teacher, but a great friend. Juha, when these words come from you, they really matter to me, and they give me more encouragement to do further work in this great subject of neurosurgery, a subject which has given us life, a subject which has given us happiness, and a subject that has potential to give new life to our patients, a subject where patients come with hope, patients come with aspirations, and we have to be true to those aspirations. We have to work hard. We have to work in anatomy. We have to work with our patients. We have to understand the needs of our patients. We cannot be heroes by operating radically but foolishly. We have to become heroes by working radically and intelligently. We have to work in the interest of the patient. We do not have to work in our interest where we are doing surgery to show preoperative and postoperative imaging. We have to work in the interest of the nerve function, because if we do good operation, we can give new life. If we do not do good operation, we demolish, we create disaster, we create morbidity, and we can kill the person. So it is a very important thing that we do a good job and we do a nice job. Juha, you agree with me, Juha?
Yes, of course. Your words are extremely good, and just continue.
Okay, we have a question, Juha, from Hamashir Shinwari from Afghanistan. Go ahead, Hamed, are you there? He may have stepped away. Okay, Omar, you have a question? Go ahead, Omar.
Unmute.
Is he there?
How are you, Dr. Ott? All colleagues, how are you? I have some notes, please. أنا Arabic. الدماغ الزجورة زي الأم الحنون. This meaning sympathetic mom in Arabic. الأم الحنون. To say أم حنون or جورة, okay? In Arabic. الأم الحنون, sympathetic mother. This one. Thank you, Dr. Ott, but I understand from you three things. First things, good anatomy, microanatomy, good philosophy, you have good surgery, beside good approach to any tumor. Okay, I think every surgery needs high philosophy to take to take good exaltation or outcome. Very, very nice, Dr. Ott. Thank you very much to all.
Okay, very, very good. Ahmed, are you there? Ahmed has a question. Go ahead, Ahmed. Ahmed, are you there? Unmute and go ahead and ask your question.
Me?
Ahmed.
No question.
No, I'm sorry. I'm just, Ahmed kept asking me to ask a question, but he's not stepping up to the plate. Hello, Ahmed.
Hello, sir.
Okay,
Hello,
go-
sir. Thank you for such a wonderful academic presentation in such a difficult topic. Sir, I have a question. How to save sex nerve, and what are your recommendations for saving sex nerve in cavernous hemangioma?
Yeah, cavernous hemangioma, the most important nerve, because cavernous hemangiomas are completely within the cavernous sinus. And carotid artery is encased by these tumors. And also the sixth nerve has a very important relationship with cavernous hemangiomas. So the tumor is very vascular and it bleeds. So if you, in the bleeding territory, if you go on coagulating, you will not be able to save the sixth nerve. It is very important that you get a plane of dissection, go towards the petrous apex early in the operation and work over the dome of the carotid artery. If you work lateral to the carotid artery, you can have issues. Over the carotid artery and work within the tumor and get the sixth nerve early in the operation. I think these are very, very dangerous tumors. There are not many people in the world who are doing cavernous hemangiomas. I think the maximum experience with various neurosurgeons in China is a good experience of these tumors. And we have done 44 or 45 cases of cavernous hemangiomas, which are difficult tumors.
Thank you.
Okay, we have two neurosurgeons from Mexico, Mauro Seguro and Victor Hugo. Welcome you both.
Hello, how are you, Atul, Goel? This was a very amazing lecture, impressive surgical procedures. So, in the cavernous sinus, we have two main trunks, the meningohypophyseal trunk and the lateral trunk. What do you think about the preservation of these very important arterial structures in the removing of tumors like this? Is possible to preserve them?
See, most important is many of the meningiomas, many of the clival meningiomas are supplied by the meningohypophyseal trunk in that area because there is a clival branch of this meningohypophyseal trunk. There is a clival artery. Am I right, Hugo? There is a clival dural branch, and which is a very important branch to supply the clival, pitoclival, and clival meningiomas. And when you are doing these tumors, you have to, you have to avoid these arteries, but whenever you need, and also cavernous hemangiomas. Many a times this infralateral trunk of cavernous sinus, the branch of, can supply the cavernous hemangioma. It may bleed very furiously. The moment you take the artery, the whole thing becomes, the bleeding stops. The cavernous hemangiomas can also be supplied by the meningohypophyseal trunk, can also be supplied by the McConnell's capsular artery sometimes. So these hemangiomas are very, very vascular tumors. Most important is when you are doing these tumors, the thing is you have to aggressively attack the tumor. You have to go and aggressively, and once you have removed the tumor, you can get to these arteries and coagulate them. This McConnell's, the region of carotid artery in the vicinity of the McConnell's capsular artery can sometimes, you can have a tear in the carotid artery when you are removing these tumors. So you have to be very safe when you have to when you are removing these tumors. In the cavernous hemangiomas, sometimes you can pull the inferior lateral trunk and you can have a damage to the artery. Then you have to take suture in that artery, and there is a lot of bleeding in the cavernous sinus, so you have to be very meticulously, you have to control the bleeding, and then you have to suture the artery. So it is a difficult job, but the whole life in cavernous sinus surgery, the region of cavernous sinus surgery, the tumors in and around the cavernous sinus are dangerous, difficult tumors. We have to be very philosophically and technically correct in doing these tumors, as you will agree, Victor.
Thank you.
Okay.
Thank you, Dr. Atul.
Hey, Mauro, you want to say hi to Atul?
Yes, thank you, John. Thank you, Professor Goel. Fantastic, as always. I have a very curiosity. At the beginning, when we are just young neurosurgeons, we are very aggressive. And in my case, I went for all tumor and very large 1-2 day surgery, very, very aggressive. And sometimes, very few times, but it happened, the patient died. I remember a 6-nerve neurinoma, 2 day surgery, and the day after he died for hypernatremia. Very terrific. And 20 years later, from when I begin, I am most conservative. I prefer to stop surgery and not to remove totally. So sometimes I prefer a small remnant, a small tumor. And I think the quality of life is better for my patient. However, when I saw your presentation, Professor Juha, and many other professors, I think that in the 60s, when many experience, you become again more aggressive. Did that happen with you, Professor Goel? It's a kind of curve, or maybe inverse curve?
You are absolutely correct. You see, in the early part of our training, we do not understand the tumors. We do not know how to break the tumor. We do not know how to protect the nerves. So we have a big exposure, wide exposure, and we do not know which our action can damage the nerve. We do not understand which action can damage the artery. As you rightly said, we can kill the person. So we learn from our mistakes, we learn from our complications, we learn from our experience, we go on learning. So more you are in the operation theater, as Juha was saying, as Juha has always said, you remain in the operation theater. You work your temple, your worship, you worship inside the theater. Learn the art of understand the tumors, and you go in your field with very open mind. Don't do anything for yourself. Do everything for the patient. Don't do anything to show a good scan or beautiful scan and show images here and there. What you have to do is you have to see that you don't damage the third nerve. If you think you will damage the third nerve, stop. Don't damage any artery, because the whole operation can finish. You do one anticlinoid meningioma, you are removing beautifully one perforator you damage, you create hemiplegia. You operate a petroclival meningioma, whole day you operate, one perforator you damage, you create disaster. So you learn these things. You learn with your mistakes. You learn with your understanding. You learn. So as you become senior, your exposure becomes less. Your radicality improves and your safety improves. I think that is the way we all have to go, and we have to go further in our field of neurosurgery and complex neurosurgery. These are dangerous things. These are difficult things, but these you have in your hand. And I know many of the people in the audience who are listening to cavernous sinus are very ambitious people. They are technical people. Those who want to do cavernous sinus surgery are no ordinary neurosurgeons. No ordinary neurosurgeon will listen to a lecture on cavernous sinus. So my best wishes to you, and I hope you will go further and further in your field of skull-base surgery.
Thank you very much. Thank you, John.
Okay, Mauro, welcome. Okay, we have a question from Dr. Abhinav. He says, should we operate on an asymptomatic cavernous cavernoma?
This is a very interesting and a very beautiful question. I will say a very intelligent question. You see, cavernous hemangioma usually present with headaches, very serious and severe headaches. And if the person has severe headache, even then you should try to avoid surgery, because sometimes the bleeding, you may not be able to save the sixth nerve and you create a very bad diplopia. So serious, severe headache is one indication of surgery. Uncontrollable headaches. Diplopia is, of course, an indication of surgery because you can improve the diplopia. And also because radiation and all those things, recently some people are talking about it, but many people do not believe that radiation is a good option for cavernous hemangiomas. I will say asymptomatic patient, I will not operate. Even moderate headache, I will not operate. Even very severe headaches, I will try to avoid surgery. But if the patient has uncontrolled headache with no drugs affecting, then I will give him an option of surgery. My indication for cavernous hemangioma surgery will be diplopia and severe headache and not relieved by drugs.
Okay. Radab, do you have any comments or questions? How you doing, Radab? Unmute.
Hello, Dr. John. I'm fine, thank you. Professor Atul Goel, no words can actually appreciate your tremendous work. It's really fantastic, as you'd like say, and it's definitely extraordinary work over more than 20 years. So we are super privileged to have your presentation and your shared experience over that years. It's really great work, and we have all the honor to have this shared experience with you. Well, my simple question would be that for that supracerebellar approach, what was your indication to do it supracellular, if that would be cleared enough?
Supracerebellar. Thank you very much. Supracerebellar approach is not a very common approach for chordomas of the clivus, not a common approach. I will not say that I will advocate this approach. You can approach these tumors by transnasal route, by using endoscope. You see, when you use endoscope, the brainstem is very far behind. On the other hand, when you come from behind, brainstem is first and very close to you. Did you get my point? When you come from supracerebellar, brainstem is very close to you and comes first in your operation. When you come from the nose, the sixth nerve, you never know where is the sixth nerve. You never know where is the sixth nerve when you are doing from the nose. But when you are doing from the posterior, you can identify the sixth nerve and you can follow and save the sixth nerve, which I have now realized that the sixth nerve is also displaced by the tumor and not encased. I am working on this article that the sixth nerve is not within the chordoma. Sixth nerve is around the chordoma. That is one very important anatomical understanding. If you want to save the sixth nerve, which is very crucial nerve in chordoma surgery, you come from the nose, you cannot save. You cannot even see the sixth nerve because when you reach the sixth nerve, it is 1 kilometer distance. On the other hand, when you come from here, you see the brainstem, you see the sixth nerve, and you can avoid the region of the sixth nerve, then go above the sixth nerve and enter into the tumor. I am not saying that this is an approach for all the chordomas and all. Don't misunderstand me. But some tumors which go very much far behind, you can have an option of this approach, which I recently published in world neurosurgery.
Okay, very good. We have a question from Ahmad Aboud from the Arkansas Neuroscience Center. Hello, Ahmad.
Hello, hello.
Hello.
Great job, Professor Goel. I enjoyed your lecture and your great work. I just want to ask a question, but it was asked before. But let me comment on Omar's statement about the Dura for the Arabic-speaking audience. He mixed describing the Pia with the Dura. The Dura matter called in Arabic al-Jafiya, that means the far mother. But the Pia is al-Hanun, which is the intimate and close mother. My question was being answered by you. Thank you very much for your great job and great lecture.
Let me tell you about this Arabic word which I used.
Oh, okay.
There are so many Arabic neurosurgeons in the world. Nobody used this from the Arabic legacy. Nobody used.
Yeah.
In the year 1990 or 1991, I gave a lecture on Dura mother, and I used this legacy of Arabic legacy for the first time. And you know what? Sam Al-Mefti, you know Al-Mefti, right?
Yes.
Al-Mefti came to me and he says, he just hugged me like this. And he was very proud of me. And he says, he was so happy to hear me. And he corrected my pronunciation. Alum al-Dimag. He said, no, it is not like this. He changed my pronunciation. And this was the first time I introduced Arabic word in neurosurgery. And I have used it in more than 300 lectures for your information. So you see, there is a lot of information in Arabic legacy, in various Christian legacy, in Hindu legacy. We must not ignore this. We should learn from this, and we should use it, because they are the creators. They are the creators from where we are born. They have given us so much information. We should never underestimate these fantastic, beautiful works done in the previous generation. And we should be in honor. So you must remember, this Arabic legacy and Dura was first used by me in skull-base surgery. Al-Mefti gave me big honor.
You deserve it.
Thank you.
Thank you.
Okay, more comments, questions from the panel?
Ask something.
Go ahead.
Atul, you certainly have very hectic days. How do you feel in the morning when you have several that kind of terrible tumors ahead? How are you organizing the operation room? What kind of team you have? You must have a machine to do. Like this is very important. This is not so simple to manage all that kind of difficult things. You have to have perfect team, perfect people around you to do these surgeries, and also good post-operative care must be there.
You will be surprised, Juha, that today I have done 8 cases, 8.
Oh my goodness.
And I have got 3 operation theaters where I run the theater, means one after the other, and my team opens, and my team, they know exactly when I'm going to join and how much they have to go. Today I did 8 fantastic cases, including 1 acoustic. Just forget, I have forgotten what cases, but 8 huge cases I did today, and that is my treasure, that is my power. Because I work in a public institution, this is not I am working for completely, there is no money involved. These patients are treated completely free of cost. I am I work in a municipal hospital. My power is my patients. I have got 16 neurosurgeons working with me at various stages of their development and various, stages of their expertise. We have got one of the very fantastic interventional radiology department. We have got intraoperative CT scan, which I don't use at all. We have got beautiful microscopes, and that is what is important. More important is a very good coordination with my team. So that is Juha. That is the that is the power. That is the power.
Yeah. Yeah, this is good. We can, Professor Goel will give in future this spring more lectures, so we can discuss also, and you can describe more about your surroundings there. So because this is extremely interesting, because very few people can do that in the world that way, like you have organized. This is very important thing also, and support from the surrounding, and this is extremely important for surgery. This is otherwise you cannot do. So how many people were involved now, Subin and Takashi-kon? Can you see that?
Yeah, speaking about a hard worker, how many cases did you do today, Ben?
For me,
You guys are hard workers.
Yes. When I visited Atul maybe 2 years ago, I said that you are my idol, and someday I will. Maybe I have more cases than you in 1 year.
How do we do today with the Chinese community?
Okay, actually, my busiest day I have 15 cases.
Wow.
Yeah. So, but Atul, it's my hero. Yeah. Today we have around 2,000 audience in the WeChat channel.
Okay, very good.
Yeah,
That's
yeah.
a lot of people to reach.
Yeah.
Okay, very good. In Japan, do you have any numbers? I don't think we're advanced yet.
I'm Dr. Kom from Showa University, Tokyo. Dr. Goel, thank you very much for a wonderful lecture. And I'm very pleased that you wrote a book with Shinshu University, Dr. Kobayashi and Dr. Hongo. I know them very well, and they were both the tycoons of Japanese neurosurgery. When using translating around my friends and other residents, and the exact number, but not sure. So the next time we will make a WhatsApp or a line. So is a SNS community to make and to disperse more Japanese to participate. At this point, so in Japan, it's 10:43 p.m. So later at night. So some doctors who are going to attend, but could not attend due to the night shift or night emergency operation. So I will recruit more Japanese. Thank you, everyone, Dr. Goel.
Okay, very good. Thanks everybody for coming. Any closing comments or questions for Juha or anybody else? Or for Dr. Goel, of course.
Dr. John, I just want to make a last comment on this presentation. I have two of my colleagues, Dr. Amir and Dr. Kais, who joined Professor Atul in last 2 years, and they were shocked and for the great work that has been done in very limited time. Just like Professor Juha said, like more than 8 to 9 cases, Professor Atul, you've been accomplished in a very fantastic way. That is really extremely extraordinary to be done in a very perfect way. So yeah, my two colleagues, if you remember them, they were very pleased and they were very honored to join you in that team with that tremendous work done in that limited period of time. So all the honor for you, Dr. Atul, for that fantastic work that would be done in very short time. Hope one day we will reach half what you have reached in that still young age. So thank you for everything.
You and you are also invited to come and visit me.
Yeah, that would be a great actually step for me in the coming years once the ward will open again.
Like you are, we have got 380 visiting neurosurgeons in last 11 years from international, outside other countries, 380. And from various countries, including Iraq and various countries. And you should also come and join.
My
Okay,
pleasure.
Very good, very good, Atul. Thank you very much, and Juha, thank you for bringing Atul to
Thank you.
the table, and welcome to the Chinese medical neurosurgery community as well as the Japan, and we hope to continue. Okay, so we have a break next week, right, Juha, and then we restart again in 2 weeks, correct?
Yeah, we have a break. Chinyan Kuala, Happy New Year. Now the rats year is ending and the ox year is coming. Is that right?
Yes,
Yeah.
yes.
So
新年快乐。
maybe it will be a better year than rats year.
It's gotta be.
Hey, thank you all. It was wonderful lecture, and we are happy to have Atul Goel also in the future, and also Ugur Ture will give a lecture in March. So we have wonderful program, and we continue, and I wish you all happy weekend. And thank you very much. Also to my friend Giancarlo Perra from Palermo, I wish good weekend. Thank you for attending here and seeing you.
Okay,
Always happy.
very good. Okay, just hang around after. We're going to go off the air, but we'll still have time to interact with each other. And we'll see you in 2 weeks.
Okay. Okay. So.